patients, same diagnosis, same pattern, different outcomes. Both were diagnosed with Chi deficiency and blastocysts, a pattern we encounter often. Both were treated using sound clinical logic. Move what is stagnant, tonify what is deficient. Yet their paths diverged. One improved, fatigue lifted, pain eased, vitality returned. The other worsened, energy declined, discomfort intensified. Why? What was unseen? How can the same pattern, treated with reasonable logic, lead to opposite results? Our training, particularly in formula studies, often provides a clear step by step process. Identify the pattern, establish the treatment principle, select a formula, then modify. This framework offers a profound sense of order. It simplifies complex presentations, especially in academic settings, and in many straightforward cases, it works, building our confidence. But this very comfort can, at times, obscure a deeper truth. A pattern like Qi deficiency and blastocysts is a description. It tells us what is present, what is visible at a specific point in time. It doesn't always reveal how the system arrived there, nor does it reliably predict where it is going. It is a static observation of something inherently dynamic. Let's reconsider our example, Qi deficiency and blastocysts. The outward signs might be identical, yet the fundamental origins, the sequence of pathological events, can be profoundly distinct. This distinction shapes the system's inherent direction and its capacity to withstand intervention. Consider three possibilities for how this pattern might emerge. Here, the primary issue is a foundational lack of vital energy. The qi is simply insufficient to effectively move the blood. The stasis is a consequence, a secondary effect of this underlying energetic deficit. The system struggles from a lack of motive force. In this scenario, the initial pathology is an obstruction, a blockage in the circulation of blood. This stasis then impedes the flow of qi, leading to its depletion as the body contends with the impediment. The qi deficiency here is a result of the obstruction, not its cause. A third possibility involves a deeper energetic imbalance, such as a fundamental lack of yang leading to internal code or an external code constraint. This code then impairs the body's transformative and circulatory functions, resulting in both a slowing of qi and a congealing of blood. The pattern of qi deficiency and blood stasis appears as a mixed presentation, but its root lies in a profound lack of warmth and functional power. While the surface pattern may seem identical, the structural direction and, critically, the system's load-bearing capacity differ significantly. An intervention that strongly moves blood might be beneficial in scenario A, but could be detrimental in scenario B if the qi is already severely depleted by the obstruction, or in scenario C, where a code needs to be addressed first. Conversely, tonifying qi excessively in scenario B without resolving the primary stasis might simply exacerbate the obstruction. We are not discussing specific therapeutic agents. The emphasis is that our intervention must align with the patient's unique pathological trajectory, not merely the static label of the pattern. So, why do we sometimes feel clinically unstable? It's rarely a lack of knowledge about patterns or formulas. Most of us have diligently studied these. The instability, that feeling of uncertainty, often arises from overlooking a critical decision layer. We become proficient at matching names, pattern names, to treatment strategies. But fewer of us consistently evaluate the underlying movement, the dynamic processes, the inherent trajectory of the pathology. Before considering any prescription, before even thinking of a formula, we must ask fundamental questions. What is moving? What are the active processes? And in what direction are they unfolding? What is collapsing? What fundamental elements are failing or being overwhelmed? What can tolerate intervention? What is the patient's current reserve, their ability to respond to the therapeutic force we intend to apply? Is their system robust enough for strong intervention, or does it require gentle support first? This layer of inquiry, this assessment of dynamic movement and systemic capacity, is often the missing piece. It is the bridge between a static diagnosis and a truly effective, individualized treatment strategy. Clinical mastery, then, begins well before the formula. The prescription is not the starting point of treatment. It is the consequence of considered judgment. It is the culmination of understanding not just what is wrong, but how it went wrong and what the system can bear. If pattern is a snapshot, clinical reasoning must read the movie. In my advanced work, I continue exploring that missing decision layer. Thank you for your time and reflection.